The diabetic foot is a very, very important and very, very costly complications which is very widely prevalent. We have amongst us today Dr. Hardik, who has been one of the topmost podiatrist and the podiatric physician in this country, who has excelled in providing diabetes care. So I just came here to introduce him, to say that in the DIACare Center in Ahmedabad, he takes care of a large number of diabetic foot patients and has built up a lot of experience in delivering the best available care to the diabetic patients. He will be coordinating the session and he will take it forward. Over to Professor Hardik, our coordinator for this session.
Thank you, sir, for the wonderful introduction. Good morning, everyone, and I welcome you all for this diabetic foot workshop. As sir said, it is the most neglected complications of diabetes, and most of the educators, they are not interested to work in diabetic foot area. So we'll just brief you about ABCs of diabetic foot during this workshop, and we have excellent speakers, Dr. Ajaiyakumer, who is additional professor of surgery, Government Medical College, Trivandrum, and he is running a Saraswati Diabetic Foot Care Center. And we have another speaker, Dr. Ashok Das, who is past president of API and RSSDI and a very senior person. I would also like to thank Dr. Jyoti Dev sir and Dr. Sunita Jyoti Dev for inviting me to deliver a talk in this diabetic foot workshop at JPEF annual conference. In next couple of minutes, I'll introduce you about the burden of diabetes in India and its staging and classification. The enormity of the foot problem of diabetic foot ulcer and lower extremity amputation is very well summarized in this quotation from 2005 Lancet editorial, which was published in honor of World Diabetes Day and its focus on diabetic foot disease. The diabetic foot can be defined as infection, ulceration, and destruction of deep tissues associated with neurological abnormalities and various degrees of peripheral vascular disease in the lower limb, and is a spectrum of foot disorders ranging from ulceration to gangrene. We must understand why there is so much concern for diabetic foot, because there are 63 million feet are at risk in India, which is expected to reach 100 million by 2025, and 15% of diabetic patients develop foot problems during their lifetime. The risk of amputation is also 40 times higher compared to non-diabetics, and very importantly, every 30 seconds one diabetic loses his limb in the world. And it is also a cause for prolonged hospitalization and high cost of treatment is involved. This is very interesting tragic rule of 15 which describes as 15% of diabetic patients, they develop foot ulcer in their lifetime. Out of this 15% foot ulcers will progress to osteomyelitis. Even with the optimal multidisciplinary care, 15% of this foot ulcer will end up with amputation at some level. This is very simple pathophysiology of foot ulceration of neuropathic, ischemic or neuroischemic ulcers. And these are the three distinct processes lead to the problem of diabetic foot, which is ischemia caused by macro or microangiopathy, neuropathy, sensory, motor or autonomic neuropathy, sepsis, which is glucose saturated tissue, which promotes bacterial growth. Undetected repeated trauma in the neuropathy is the usual cause of ulceration in diabetic foot. I have tried to distinguish features between neuropathic and ischemic diabetic foot. In an ischemic foot, there will be a claudication pain, while in a neuropathic pain is very unusual. However, some patients may have symptoms of painful diabetic neuropathy. While a clinical examination, ischemic foot will be cold and palpation cannot be felt, whereas in a neuropathic foot, it is warm and bounding pulses can be felt. In this slide, I have mentioned the most commonest sites for ulceration in a high-risk diabetic foot. In next couple of slides, I'll show you the simple classification of diabetic foot ulcer, which is nicely described by Wagner et al. The grade 0 means there is no ulcer in a high-risk foot, only presence of neuropathy or peripheral vascular diseases. Grade 1 is superficial ulcer involving full skin thickness but not the underlying tissue. Grade 2 is a deep ulcer penetrating down to the ligaments and muscle but no bone involvement or abscess formation. Grade 3 ulcer is deep ulcer with cellulitis or abscess formation, often with osteomyelitis. Grade 4 is localized gangrene, and grade 5 is extensive gangrene involving the whole foot, which may require amputation. So whenever the patient comes to your clinic, he or she should be evaluated for different aspects, which includes clinical examination, neuropathic evaluation, vascular assessment, orthopedic assessment, which we will see in detail one by one. Neurological examination can be done by 10 gram monofilament vibration testing using 128 Hz tuning fork, test of pinprick sensation, ankle reflex assessment, and testing vibration perception threshold with a biosthesiometer, which is not possible in all kind of setup, but it is recommended for the documented risk assessment. The sites of assessment are grade 2, first, third, and fifth metatarsal, and the heel. Vascular assessment can be done by simple clinical examination such as palpation, presence of hair, and temperature of foot. And if there are any concern, further evaluation can be done by ABI, toe pressure, or TCO2, which are not very commonly used in a day-to-day practice, but it is required in a patient where there is a requirement of surgical interventions like amputation. Orthopedic evaluation is to look for ulceration, any deformity or prominences, and contractures. In a country like India, it is not always feasible to provide foot education in a mass. So there is need to stratify these people according to their level of risk, which is as simple as that. Patient with no foot deformity, physical or visual impairment are low risk group patients. If there is presence of neuropathy and no past history of ulceration and presence of PVD, you can put them in a moderate risk group. And those who are having neuropathy and or PVD and past history of ulceration are the high risk population, which requires special attention to prevent them from gangrene or amputation. Low risk patient, it is required to for them to go through the comprehensive foot examination at least once in a year as recommended by simple questionnaire, clinical examination, and assessment of neuropathy and peripheral vascular disease. They should be also provided a very brief education about foot care in diabetes. Moderate risk group patients will also need comprehensive foot examination, and apart from that, it is necessary to inspect their feet at every office visit, give them special podiatry care, intensive education, also try to detect and manage the barriers to foot care, and give them therapeutic footwears if needed, which will be described by Dr. Ashok Das in a coming talk. And those people who are at high risk will require a special focus regarding their foot care, which includes mark them as a high risk patient on patient's file, give special podiatry care such as cutting toenail and calluses, provide customized footwears, provide intensive patient education, which we will see in next slide, that what are the points we need to incorporate while patient education. This is very important slides for all of you, because we see patient who are the high risk patient in our day-to-day practice. We don't see a patient who requires surgical intervention most of the time. So these patients who are at high risk, we should educate them intensively so that they do not develop further complications. You advise them to keep their feet clean and dry, wash feet daily with warm water, use a mild soap and rinse well, dry feet thoroughly, particularly in between the toes. Do not go bare feet, trim your toenails straight across, powder feet and shoes every day, wear comfortable shoes, wear fresh socks every day, and avoid using sandals with toe grip. So the key message is to stratify people according to their level of risk, educate those who are at moderate or high risk. Improper shoes are the most common cause of ulceration, and identify the problem early and treat promptly. The management approach of the diabetic foot is to be multidisciplinary to save the maximum number of limbs. Proper, timely and adequate management coupled with foot care education can save 80 to 85% amputations. High risk sensitivity to the senseless foot of patient is needed by the healthcare provider. Thank you. And now for the next session, I invite Dr. Ajaiyakumer.
The moderator of the day, Dr.Hardik Chandarana. At the outset, let me express my sincere gratitude for Dr. Jyotidev, Mrs. Sunita Jyotidev and his team for giving me this opportunity. And today, I will be discussing briefly on the clinical examination of high-risk foot. There's a problem with the color. Can you adjust? So, the concept of high-risk foot is the one which I want to highlight. In your day-to-day practice, so I bring greetings from Government Medical College Trivandrum, my alma mater, Saraswati Hospital, Parashala, Trivandrum, a center for diabetes, diabetic foot care and metabolic surgery, and Saraswati Diabetic Foot Care, Cochin. So as an introduction, I want you to look into these pictures. These are all pictures taken from our own patients. At the first look, it may appear a very neat, clean foot, okay? Just go through these pictures, right? I'll go back again. See, this is a very dangerous foot, very dangerous feet. How? You can see the callosities on the first metatarsal head, fifth metatarsal head, and on the heel. It's a tripod foot. Second, see the muscle, soft tissue mass of the sole, very minimum. It's a intrinsic minus foot. There is no time to discuss all those things. It's a foot where all the short muscles, interossei, lumbricals, soft tissue pad, all lost. The foot is consisting of the bones, the long tendons, and little bit a thick tissue covering the sole. That's an intrinsic minus foot with the tripod callosities. Very dangerous. I'll show you how. See, this is the next stage. What will happen to the callosity? It is called subcallosal hemorrhage. It's going to break down. The patient will simply walk on the callosity and you will develop a trophic ulcer. Okay? Right. See, this is another scenario. This lady, very young, 32-year-old diabetic, had an intratrigo with an infection spreading towards the deep plantar space. Luckily, we could save her. So the wound has healed well. You are very happy and you are discharging the patient. But the happiness will not last longer. Why? This is a biomechanically altered foot. She is going to have an entirely different weight-bearing pattern. This area is fragile, weak, and more likely to have problems. So she is going to ulcerate again. Right. See, a very well advanced, not well advanced, bad diabetic foot. You have mid-foot collapse, rocker bottom, and pressure point on the center of the deep plantar, then deep plantar arch. Now it has become a rocker bottom. So soon her fate will be like this. Understand? Right. Then with one more point I want to add. This poor man was traveling as a pillion rider on a two-wheeler. He was going to invite her daughter's marriage. Unfortunately, his footwear went off. He was placing the foot on the silencer. Okay? Right. Second, very common, neglected, not looked for condition. In Trivandrum, it is called Iran Kale. In Central Travancore and North, it is called Valam Kadi. Simple intertrigo, which can be very simple. Patient will not have any problem. Why? There is no pain. There is no itching. The toes are crowded. Okay. What will happen? Secondary bacterial infection, intradigital infection, the sloughing of the tendon in the plantar region, deep plantar abscess, loss of soft tissues of the plantar aspect, becomes a useless foot even if it is saved. So a small care can save the foot. And my dear friends, to begin, I would like to make a categoric statement. No diabetic foot ulcerates spontaneously. Okay? You know what diabetic foot is. So a foot will ulcerate with a cause. Okay? So with this, I would like to highlight the concept of high-risk foot. High-risk foot is a foot that has developed one or more of the following risk factors for ulceration. Even one is enough to call it as a high-risk foot. Neuropathy, ischemia, deformity, and history of previous ulceration. I have shown all the examples in the beginning. Okay? Right? Dear friends, we'll go to the theory part. What are the objectives of clinical examination of the diabetic foot? There are three questions. One is LOP. Is there any loss of protective sensation? The sensation which protects us from injuries, let it be your cornea, let it be your foot, let it be your fingertip. It is a sensation which helps keep you away from injuries, isn't it? So when there is loss of that sensation, the foot becomes vulnerable to injury. Is there any limited joint mobility or deformity? I will show you what limited joint mobility later. Deformity is the one which is the irreversible change, structural change that has occurred in the feet due to the bony, muscular, and soft tissue peculiarities or the changes occurring in a diabetic foot. Okay? Then, as I said earlier, previous history of ulceration will tell you so many things. The foot has got all the risk factors. That is why it ulcerated. It has healed. So it added one more risk factor. What is that? The biomechanical alterations as a result of the new scar, new shape, isn't it? The pressure distribution changes. So these are the three things you want to look for in a clinical examination of foot. It's not very difficult. My point is, it is very simple. So as Professor A.K. Das sir has coined the name ABC of diabetic foot workshop. It is an elementary thing I am telling. I am not going to teach you the high funda theories, the glycosylation of the soft tissues, those things I am not mentioning. It's very, very simple things. So you look for the pathological causes which creates ulcers. Very simple. Peripheral neuropathy, peripheral occlusive vascular disease, and structural abnormalities. Right? So this will help you to determine the patient's risk status, as Professor Hardik Chandarana was discussing about it. Then patient's educational needs. The most crucial thing in your diabetic foot management is patient education. You have to keep one person dedicated for diabetic foot care education. Then you have to decide on the management. These are the three implications of your diabetic foot examination. So who will do this? It can be done by anybody. Your physician assistant standing on your cabin can do. Your podiatrist can do. Your junior doctor can do. Your nurse can do. So it is very simple. It needs little bit of training if it is a paramedics. If it is a doctor, no need of training. Just give him a booklet, he'll do it. So it is very, very crucial to find out a person, to spend some time with your diabetic foot patient or a patient with high risk foot in your consultation room or among one of the, as a team member, to do this. So these are, I am not taking much time because we want to spend more time in the workshop. So these are all self-explanatory. Then while you inspect, look for nail, skin, deformities, vascular assessment, neurological assessment, footwear examination, and ulcer assessment. Ulcer assessment doesn't come in this purview because it is a high-risk foot, not an ulcerated foot. See, very common to see pyronychia in diabetic foot. It's a wrongly cut nail going ingrown toenail with a moist environment leading to pyronychias. Too long nails. Then fungal infections, I have already told you. Wrongly cut nails. Thick, hypertrophied, ischemic nails. You can imagine. You need a bone cutter to cut the nail. You remember. Okay. Right? See? All these things I have explained. One thing which I have not explained earlier is a fissured sole. I have at least 3 patients as IP now who has got bad diabetic heel pad infection, started as a infected fissure sole. Very, very crucial, but a small intervention. A 5-second spent in your consultation room can save the limb. So fissure sole is very important. Intertrigo, then skin color changes, then the callosities. This concept is an early concept which tells you that your patient's foot is going to be in problem. That is called LJM, limited joint mobility. Very simple. You have the glycosylation of the hemoglobin. Just like glycated hemoglobin, you have glycated soft tissues. What will happen? Loss of resilience of the joints. The elasticity is gone. The mobility is restricted. The earmarked joint is first MP joint. You just dorsiflex the first MP joint. If it is less than 50%, you can for sure tell that this man is going to have problem. So it's an early sign. Please look for it. Then various deformities, an array of deformities, starting from hammer toe, claw toe, forefoot deformities, hallux valgus, hallux rigidus, all as a result of structural changes. You can see the 4th one, the sole with a callosity in the center. Very dangerous situation. Mid-foot collapse. It is going to be a rocker bottom. Instead of a high arch, the reverse, just like your umbrella getting inverted during a rainy season as a pillion rider. Isn't it? Same thing happens. You are going to have a rocker bottom and you are going to get an ulcer. Okay? Then advanced Charcot's arthropathies. All right? So these are the diagrammatic representation for academic interest. Hammer toe has got no flexion in the distal interphalangeal joint, whereas claw toe has got flexion of all interphalangeal joints and hyperextension of the metatarsophalangeal joints. Right? And the mechanism of rocker bottom, you can see joint, the Lisfranc joint is a culprit. There is fracture. Then you have the collapse of the midfoot, the tarso-metatarsal joints, isn't it? Right. And vascular assessment. Don't think that you need a lot of instruments, vascular assessment. You are just undergraduate days. when you were taught by the physiology teacher in CVS examination how to palpate the dorsalis pedis, how to palpate the posterior tibial, how to palpate the anterior tibial. Just 5 seconds will be enough. Just palpate the medial malleolar region for the posterior tibial, just in front of the ankle for anterior tibial, and in the first interdigital area near the head of metatarsal for the dorsalis pedis. Then you have an instrument called handheld Doppler, which will tell the impalpable pulses even if the systolic blood pressure is 80 or 70 or 60. You can detect, you can assess angle brachial index, that I will describe in the workshop part. So there are a set of patients who have major occlusions where revascularization is needed. Then you have sensation assessment, very simple, cotton wool. Then you have monofilament, everybody is familiar with monofilament. It is nothing but a filament. Just apply pressure on these points, you get sensation checked. Then you have tuning fork if needed. Then biothiometer, I will be demonstrating in the workshop. Then skin temperature, foot pressures, podia mat is there to assess the pressure points. And you have got different scans available. Then inspect the footwear, very, very important. See, this man has an injury on the first metatarsal set. See the corresponding portion of the footwear, worn out. He did not know, okay? Then X-ray, very important, very informative. See, an advanced Charcot's arthropathy. Then 2-minute examination, include all these 10. If one is present, it is a high-risk foot. Then this I want to incorporate in your daily practice. Ask him whether you have any foot problem. Yes means it is an important clue. Then palpate the pulse. Are both pulses palpable? Is the sensation intact? Is there any evidence of foot deformity? These 4 things will take less than 30 seconds. Please incorporate this into your clinical practice. So, my dear friends, as a conclusion, concept of HRF should be popularized among all doctors treating diabetes. Diagnosing HRF and initiating podiatric care prevents ulceration, infection and amputation. Diagnosing HRF is simple and can be done in your consultation room. A 30-second foot examination, if needed, leading to 2 minutes foot examination followed by an X-ray, VPT and ABI. With these words, I conclude my talk. Let us take the feet to our heart and save the feet on limbs of our patients. Thank you very much for the patient listen.
Ajay, thank you very much, dear friends. We are overwhelmed by your presence and the encouragement you have connected. Now we have, dear friends, as you know, as you saw that we have named it as ABC of diabetes foot because we want to give some basic issues which you may be already knowing. But these are the clinical practical issues which are important, and the next part, this half an hour left to us, will be spent on demonstrating the practical aspects of diabetic foot. Now, I'll be demonstrating only in 5 minutes a few important issues regarding the diabetic foot. I will talk about what do we mean by podiatry and podiatry kit that you must have in your armamentarium, and dear friends, these are the trademark of the International Council of Wound and Diabetes Foot Group. You can see the legend here, and with a collaboration from USB, we have just prepared this for a course, which is a pan-Indian course. That course is separate. Yesterday we had in Calcutta, and last week we had in Lucknow. There is also 3 courses we have planned for the city of Trivandrum. That's why I'll be very brief to tell you that this podiatric kit is given to all the participants. We have 1,000 participants. What does this kit contains? The kit contains the podiatric kit, which is given to all the participants, not here but in the other program I'm referring to. It contains a scoop What is the scoop used for? Scoop is used for removing the non-viable tissue, and the probe, this is scoop, and the probe is probing and assessing the depth of the wound. I'll be demonstrating that if we have some cases, or I'll show the instruments which helps in deciding the management of the wound, whether it's osteomyelitis. Supposing you probe and find a bone, that is means there's an osteomyelitis. We use the files. This is usually file, the beauticians also use it for filing the nails after clipping it. It is essential to file, otherwise the sharp ends of the nail can always affect the skin or can affect your cloth and the socks. We have got a scalpel with knife handle and the scalpel size 3 and 4, and we have got 3 for the smaller blade and 4 for the larger blades. We provide, this must be there in your kit. We provide a scalp blade number 10, and this number 10 has a curved edge. It is usually, we use this for making a small incision on the skin and also use it for dressing the callus. You know, I'll talking the callus, for the callus removal also use it, and also while dressing the wound. Now this sculpted blade number 15, we use it for making short and precise incisions, and also it is used for trimming the calluses and dressing the wound. Now this is a nail clipper which Dr. Sahab said, Ajay said, a bone cutter. This is usually the best one we use in our kit. Now the stainless steel nail clippers, and there is a way of clipping the nail. You have to keep your hand in front of the nail so nail does not come to the eyes, and this nail clipping is very important in the diabetic. I'll come to this why. And we have the tissue nippers. The tissue nipper, fine edge for cutting those loose nails or skin as close as possible, and we have straight files for filing the nails. So dear friends, as I told you that we have less time, and the next session will be beginning exactly at 12. I can see Arvind Gupta already here, and Ravindran is already here. They will push us out from this hall. So I mean, I'm very conscious that we should not fall down. So that's why I'm very brief to tell you that it is this. So I'll just pass on to Hardik, who will be speaking to us about the offloading. Before that, I'll just show you, I'll just take you through, because I hope that Dr. Sahab will have some live. No, just go back to other presentation, other one. Yeah, put the nail. So Dr. Sahab, the nail is a big issue in diabetic foot, and I'll be very brief to say you that the nail is an asset, but can become, the nail has got so many parts, no details of it. How to cut the nail is very important in diabetic foot, because in neuropathic pattern, the nails can become infected, onycholysis, and nail can become discolored. These various types of infection it can occur. And you know, there are few all types of onycho. There's onychomycosis, onychocryptosis, and onychographosis. This is onychomycosis. You can see the nails which are all infected by the fungus, and we have the various types of nail lesion. This is a type of ingrowing toenail, which also I think Ajay said, and there's a way of taking this. These are the type of nails we get, and we get thickened nails. We call it onychogryphosis. So onychomycosis, ingrown toenails, and the thickened nails. These all occur in diabetes, and you have to take care of it. So all that I want to give you the view that diabetes podiatry is a separate science by itself. We are trying to open a course in which we'll offer it to the paramedics or whomever you depute, the various types of procedures. It is in the offing. The course that we are offering right now is for a 2-day course where we provide all these things. Dear friends, at this stage, maybe I will pass on to Dr. The only last part, your time, Hardik? We have time. You see, these are the type of nails we have. Go to the... Oh, leave it now. I'll tell you only one more thing, that the callus removal is a very important issue. No, that's all right, leave it. I'm not able to focus the callus removal because it is difficult to focus here. But I must tell you that you cannot be callous about the callus. If you are callous about the callus, then you will pay for it. The callus is the forerunner of an ulcer, and the callus has to be debrided till you get a minimal bleeding. So I have just told you very briefly what is a podiatric kit, what are the nail changes, and what is callus. I will hand it over now to Hardik, because he has to go somewhere, so he will talk to us very important aspect of offloading. Then I'll come back again to demonstrate the others.
Thank you once again, sir. And sorry for interrupting the schedule, as I just got the message that my flight is been slightly preponed. So I'll take you through the different offloading techniques in next 5 minutes, which are bed rest, walker, total contact cast, modified footwear, rocker outsole, and insole stress relief pad. Total contact cast. In patients with peripheral neuropathy, it is important to offload at-risk areas of the foot in order to redistribute the pressure evenly. Inadequate offloading leads to tissue damage and ulceration. The gold standard is total contact cast. This is a well-molded, minimally padded foot and lower leg cast that distributes pressure evenly over the entire plantar surface of the foot. It ensures compliance because it is not easy for the patient to remove. Using total contact cast in patients with unilateral uncomplicated plantar ulcer can reduce healing time by around 6 weeks. These are few disadvantages of total contact cast. It must be applied by fully trained and experienced practitioner. It may cause skin irritation and further ulcers if applied inappropriately. It prevents daily inspection, may disturb sleep, makes bathing difficult, and patient may not tolerate it, especially in warm climate, and may prevent patient's ability to work. This is the picture I had shown of total contact cast, that how it should be done. And these are few other different offloading methods like remover, cast walker. It is similar to pressure reduction to total contact cast, more acceptable to patient but reduced healing rate compared with TCCs. Easy to remove and can be used in infected and ischemic wounds. Scotch card boots are a lighter and stronger alternative to plaster of Paris cast. Padded cast covering to the foot of ankle. Extensive practice experience but no comparison data available with TCCs and can be made non-removable. Healing sandals are designed to limit dorsiflexion of the metatarsophalangeal joints, improved distribution of metatarsal head pressures, lightweight, stable and reusable, and can increase the risk of falling off for patients with poor balance. It requires time and expertise to produce and modify. Crutches, walkers and wheelchairs are to be provided for patient who needs complete offloading of the foot. Patient need good upper body strength in this. Patient who do not perceive any limitation in function of the affected limb must understand the purpose of this device and be motivated to use them. Wheelchairs may be difficult to use in unmodified homes. And these are the few pictures I had shown of different offloading techniques. And this type of footwears we provide for high risk patients or where there is a presence of ulcer in forefoot or heel areas, and high risk patients also can be assessed by foot scan, and they can given designed footwears, customized footwears accordingly. However, in India, recommended devices are not available, and all that can be offered is a cushioning contracted from the items from local shops like kitchen sponge and upholstery forms. In many regions, walking barefoot or with poorly protective sandals is normal. Replacing this by advising shoe wear may be culturally also unacceptable or may create some other foot problems. Patients should also be advised to limit standing and walking and rest with the foot elevated. Thank you.
Dear friends, what Dr. Hardik has said is that for a neuropathic ulcer, you take the pressure off and it will heal with rest and antibiotics. Now you can ask few questions to Hardik. Hardik, you have to reach only by 12:30. So it takes on a Sunday 15 minutes from here. You have to reach by 12:30. We already checked in. Flight cannot leave without you. And going to Ahmedabad is our PM's place. It cannot leave without you. So you answer few questions. You can ask few questions to Dr. Sahab. Yes,
You can ask any questions related to diabetic foot and education. I'll be happy to answer. You can also come out with some suggestions also which you feel may important and which you experience in your day-to-day practice.
Christensen. I'm from Denmark. I've been treating diabetic feet for 30 years. I work in a hospital. I have 2 clinics. I'm deeply honored to be here, and I'm very, happy to hear what you do about the diabetic feet. What I wanted to ask you is this orthopedic foot where you're giving to the people. Do you make some insoles in it
Yes, we provide customized insoles as well
Okay.
for pressure offloading.
See, what happens is that we strongly believe, as you rightly also know, that about 90%, this is a very important piece of knowledge, the 90% of diabetic foot do not require a customized shoe. They only need a shoe which is bought in the evening because the foot size is larger in the evening. They need a shoe which is roomy. The top is not, I don't know, my daughter is not here. My daughter wears shoes where this is pointed to the infinity. So I can tell because she's not here. So yeah. No, yours is perfect. So, this is, and so you have a roomy shoes and we have a soft cushion. So the foot pad is supported. But rest 10% is what you said, absolutely correct. They need a customized shoe, and the customization is done by giving half shoe where you take off the load, or by giving few other things like we provide them, as doctor has said, provide them cushions by providing the toe separators. We providing supposing a plantar ulcer, we make a hole in the special sole so the wound is offloaded, so that is done. And we have in many parts of the country the shoe manufacturers who work in close collaboration with you, and the big institutes like mine, we have the shoe preparing machines and people employed for that. Now in India, because of the cost, we used to use a MCR shoe. MCR shoes are used for the leprotic foot, but that black color is a taboo. So now we have changed it to a different type of shoe, is not black and is well accepted. Yes, he is the moderator.
I heard about your kids.
Yeah. Yes.
Kids you're going to do.
Yes.
Why don't you make an education out of that? In Denmark, we have an education of a chiropodist, and it takes 1.5 years, and we treat the people.
I wish you are from which institute, which university? Denmark University. From which place you have come?
I come from Copenhagen, and we have 2 schools in Denmark that.
You see, the chiropodist in our country is not available. We do not have any. You see, people have all these young girls. They go to beauticians before marriage, before parties, before da 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 da.
Yeah.
But you see, we do not have a concept of a foot care.
But you're starting it.
We are charging on a distant mode, and we are charging with the Ali Foster.
I'm sorry.
Ali Foster, Ali from the
no.
King's College Hospital.
No, I don't.
No, whom do you know? Podiatrist from England.
Nobody.
Okay, Catherine and all.
The man,
We are starting a course in distant mode,
Okay.
but we do not have a structured chiropodist course in our country. We have the shoe course that is given by the Department of Leather Industry, but
Okay.
we want a chiropodist course.
If
But
you
you are quite correct. But in India, we are totipotential. Hardik is a physician who sees patients, and his name in the Forbes list, one of the richest doctor of the country. At the same time, he is also doubles up for, we have got multitasking people. To be honest with you,
Yeah.
we have in our clinics, we have 1 or 2 nurses. They double up for giving injection, giving education. One of them specializes in chiropody. But what is ideal is what we are saying. We must have dedicated chiropodist for that.
Yeah, but I just had an extremely nice session before I came here.
We have not finished, madam.
Okay.
There is another
So I will
12 minutes. The
just
gentleman
be
is
quiet.
pushing me out, but we have 12 minutes more. So his very interesting part is there. Now, dear friends, I have got 2 photographs to show you, but it is not opening here. We have 2 characters in Hindu mythology. One is Lord Krishna and other is Bharat. Lord Krishna, when the friend comes to his house called Sudama, he washes his feet. We show this photograph. I'm sorry I'm not able to show this. We say that we should take care of the foot. I like your face. That's our primary education. And we had another person in our mythology called Bharat, who just took the shoes of his elder brother and ruled for 12 years, getting inspiration from the shoe. We use it not for that purpose, use it saying that shoes, as Ajay said, is of paramount importance. So so diabetic foot is, education is ingrained in our culture, both by washing the feet by our Lord and by ruling the country with the Paduka, we call it shoe, by Bharat, of the Mahabharat character. So from the Ramayana. So therefore it is very much akin. And you know, the basic fact of diabetic foot is that we have to care for the diabetic foot by the doctors, by the patient themselves. We have do's and don'ts which we give to everybody in the clinics, and we run videos and shows which I'll show in a minute. In the meantime, we have got 3 instruments which you will go through. You can leave. Just download. नहीं ड्रेसिंग बाद में ये ले आओ उसको ले आओ. So we are showing 3 instruments: biosthesiometer, the ankle brachial Doppler, and what else you are showing? Quickly.
Just Harris mat.
Harris mat for the pressure.
Yeah. So, my dear friends,
download.
it's a basic 3 investigations which should be present in your consultation room. Very simple. The point is, it's not a complicated, sophisticated equipment. It's not costly. So, there are 3 in number. One is, this is called biosthesiometer. The idea is, it creates vibration in using electrical energy in the form of millivolt. So, it is the vibration perception threshold you are checking. Okay? Your palm can perceive a vibration produced with 5 millivolts. But if your feet cannot perceive a vibration produced by 10 millivolts, it is more than 10 millivolts, it is abnormal. So 10 to 25 is mild neuropathy, 25 to 50 is moderate neuropathy, more than 50 is severe neuropathy. Simple. I'll just demonstrate how it is done. Can one of you come and volunteer? So you can do it, not as a patient. So this is the hand. This is a hand probe. This is the hand probe where you get the vibration. Just apply without pressure. The important thing is proprioception should not be confused with it. Just apply pressure.
52. So we'll be there by 12:50.
See, the patient lies in supine position. Just make the instrument acquainted with him by telling him, see, this is the vibration you are going to get. You are going to feel it. So take him into confidence. Then you need 3 points in the sole and 1 point on the dorsum. So, see, this is the, I am starting with 5. Okay, see, with 5 he can listen. Then slowly you increase to 10, 15. In diabetic neuropathy, you won't get any sensation if it is a severe neuropathy, even if it is more than 50. See, more than 50, vibration, nobody can tolerate. Even you just feel, see, you cannot tolerate. This vibration cannot be perceived by the patient. Just do it. I will start with 5, right? Okay. Yeah. So it's very simple.
You see, it is the simple principle is that this vibrates, and the vibration is converted to ohms. Exactly. And we express it as the ohms and millivolts, and if it is, we by absolute number, very easy. So if it is above 25, we say definite neuropathy. Between 15 to 25, prone for neuropathy, and below 15, there may not be neuropathy.
Mild, moderate, severe.
Severe. So that's how we screen everybody for the and you know, as the vibration sense is carried by the large fibers. So this is a large fiber neuropathy where you get the vibration sensation loss. We also do the 2 other tests. We do the ankle brachial index.
Okay.
Dekha do jara. Yeah, you do not do it. This is that's what. Sorry.
This is handheld Doppler just to find out the pulsation in the three arteries, named arteries, the dorsalis pedis, posterior tibial and anterior tibial. Yeah. Just I'll show the sound.
First, we measure the brachial pressure.
See?
You can see the sound. Then we raise the BP cuff. At what level this sound disappears? That is the pressure at the ankle. Am I clear? So we express this ankle versus brachial. If it is less than 0.9, it goes in favor of ischemia.
Exactly.
So that's how we do
And
it.
one more point, if it is more than 1.4 also, it is abnormal. It's a calcified vessel. So between 1.4 to 0.9 is the normal range. You get a bounding dorsalis pedis and an ABA of more than 1.4, it is not good. Okay? Ischemia is there in the micro level. Okay? Yeah, you in the calf level, in the calf level, you apply the cuff, then inflate the cuff, see the sound disappearing. Okay, posterior tibial, dorsalis pedis, if needed, anterior tibial. Okay.
This is a very simple instrument. It's very inexpensive.
In the arm, we'll tie the cuff with just 1 inch above the.
By checking normal blood pressure.
Cubital fossa. In the leg, what's the position?
Over the calf prominence, just over the calf muscle. Yeah.
And measure the blood pressure. Dear friends, the other thing that we like to demonstrate, the neuropathic ulcers, as we showed in the table, occurs on the pressure points. Whichever the pressure points, like the metatarsal joints, like the other toe heads, it occurs there. So it is very important to find out the foot pressure. You can do this foot pressure by doing a very costly instrument called the pedobiography. But you can do it also this instrument, which does not cost anything. And the whole pressure, you can show them. You can see the pressure point of this particular patient. The pressure point is what the density of the shadow. So you can, it is just like a stamp pad. But here the pad is such that the whole foot, the patient can step on it and it will be reflected in an ordinary paper. The company also provides separate special paper, and you can plan out you can see the entire foot and the distribution of pressure, and depending on the pressure, you can give a customized shoe. Where the pressure is high, customized shoe.
Yeah, there is a software available that will tell you a color coded image, modified. If you just feed this, scan this and put it in the computer, you get this one.
Name of the name?
It's called Podia Eye Scan. It's a Harris mat. Very simple. You just apply the ink pad, the ink in the ink pad, stamp pad. Just apply it, put the paper, asking to stamp on it. Just a normal walking.
It is just like
Very
a
simple,
rubber stamp.
very simple.
Rubber stamp,
You get-
but the whole feet comes in there.
Exactly. So that you can see the pressure points. Correspondingly, you get red dots on the pressure points like first metatarsal head.
So, dear friends, we have last 5 minutes.
Okay, sir.
So we'll like to have very short questions and equally short answers from Ajay.
So,
Toe pressure, you see, toe pressure measured by the same ankle
Transcutaneous.
brachial index, but
Yes.
we have got a separate probe which comes with this for this toe pressure.
that is called
There is-
transcutaneous. Is it?
We don't
No,
have
not
it here.
have it.
Now there is another way of doing it, what Dr. Saab is telling, that's called TCPO2, transcutaneous oximetry. So what we do, we apply one probe at the tip of the toe. Supposing you apply this pressure at the tip of the toe, one probe it here, and then heat both the probes to about temperature, little above the skin temperature. They will consume oxygen. This is taken as 100%. Whatever oxygenation there is expressed as a percentage called RPF, regional perfusion flow index. So that is also one good way of doing it. It costs about 9 lakhs. We do it every day, very cost effective. Radiometer is the company. I'm not advertising for any company. It is the company who is the machine with the cheapest radiometer, and it is good. We have used it. Next question.
So let us say 1 minute about the dressing, because they are all doing.
It's okay. Before that, one question. Dressing will be last. Yes, Doctor.
Can you
very
tell me
important.
the cost of these devices?
Cost, it is very inexpensive, Doctor. It is very inexpensive. Yes, sir. We are bracketing. The very inexpensive. Now this Harris mat You contact,
8,000 rupees or 10.
there is one gentleman called Ilango, and you contact Ilango, he will give you very discounted price. And the pocket held Doppler used to cost 8,000. Now he has increased the price to 14. Depending on your face, he will tell you the value. Then the biosthisiometer used to cost about 8,000. I gave him the first machine. Now last year he paid income tax of 3 crores. So he is so this is a very, it used to be very free. Now he charges 27,000.
Exactly.
27,000. So money you don't worry. Saving a leg is valueless. And it is less than any money. It is very inexpensive. It is not a big machine like a pump. I think before that dressing.
Yeah, 1 minute about dressing the time. See, there are a few points. I'll take less than 1 minute. When you do a dressing, never make a tight bandage. Never make a loose bandage. Number 1 point. Second point, when dressing will not replace a surgical debridement. Okay, that is very important. Number 3, dressing materials. You have plenty of materials available in the market, but judicious use of classical materials, absorbent gauze, pad, bandage will give equally good results. Number 4, you have to use local applications very carefully. A granulating wound, no infection, no discharge. Please do not use povidone iodine. Please do not use hydrogen peroxide. You apply normal saline. That is the most physiological solution you have, close to your blood, 0.9% saline, IV fluid. Then apply a loose Tule, Vaseline gauze, then pad, bandaging. Okay? So dressing is very important. Dressing is the one which gives you good environment, conducive environment to promote healing. It can be deleterious also. I have seen so many wounds having large granulation tissue, daily hydrogen peroxide, betadine, the wound will never heal. So never apply a loose bandage, never apply a tight bandage. No betadine, no hydrogen peroxide. It does not replace a surgical debridement.
So it is time that we wind up this. I thank you profusely for being present in this hall and taking part by that what is diabetic foot. And I'll have a presentation of a memento to Dr. Ajay for his passion.